Afternoon, everybody. I hope everyone can see and hear. Welcome to the HCV Action webinar, the next 2 years to elimination. I'm Steve Ryder. I chair HCV Action, and I'm chairing this webinar today. I guess the objective of the webinar is to really sum up where we are now in terms of that progress towards the elimination target. I think everyone's aware that the WHO target is 2030 for elimination of hepatitis C to be achieved, and NHS England have a more ambitious target of 2025, so we're only 2 years away from that. I think certainly the reflection of most of us who've worked in the field is that a huge amount has been done and achieved over the last few years. And there are still some very specific remaining challenges for us, both to achieve those elimination targets, but then to maintain it, which is perhaps some of the critical things that we're going to hear about today. We have a number of speakers to give us different perspectives on it. So Mark Gillyon-Powell, who's head of the programme for Hep C elimination at NHS England. Mark's going to provide us with a national overview of progress towards elimination, and particularly highlight some of the successful elimination initiatives and some of the areas where we still have challenges. Ruth Simmons, who's the epidemiologist at the UK Health Security Agency, will give an overview of the latest data, and perhaps one of the real achievements of the ODN structures is providing a lot of that data. But I think Ruth will show us how useful that information is, but also highlight perhaps some of the gaps where we don't know what we need to be able to plan that elimination. We've then got Sally Bufton, who's the hepatitis ODN nurse and the manager of the Birmingham Operational Delivery Network, who will share with us some examples of successful initiatives and the remaining challenges within her ODN, and outline, I think, some of the key things that need to be done to try and address those challenges. And finally, we've got Stuart McPherson, who's the clinical lead for North East and Cumbria ODN, who will provide an ODN perspective on the successful initiatives that have been run there. And again, the remaining challenges in that geographical area. I think a lot of these will be things that we are all going to share in terms of those challenges. It'll be very interesting to see how Stuart's tackled it in his geography. So we hope that the event will be useful for anyone directly or indirectly involved in hepatitis C elimination. And we would say everyone is feel free to add any thoughts or reflections of your own. And you can do that by typing questions into the Q&A or chat box at any point during the session. They'll be answered during the question and answer session at the end of the talks. We are recording the webinar and we'll publish it afterwards. I think that's probably the end of my spiel. So to give you a little bit of background, and what I'm going to do now is hand over to Mark Gillyon-Powell, who's going to start with a national perspective. Mark.
Thank you, Steve, and thanks to HCV Action for asking me to come today and speak. So I'm very pleased to be here. I probably know most of you that are on the webinar, but as Steve said, I'm Mark Gillyon-Powell. I'm the head of programme for hepatitis C elimination at NHS England. Next slide, thanks. Yeah, we can skip that one. So a lot of you will be familiar with this, and apologies to those of you who've seen it so many times before, but I do try to include it in every single presentation that I do because the progress that's been made is really quite incredible and is really the foundation of why we keep being given the opportunity by NHS England and others to prioritise Hep C elimination, because we've shown that actually we can do it and it works and it has huge benefits to individuals, communities, and the NHS as well, actually. So we've treated around approaching 90,000 people since 2015-16, which is a huge number. Obviously, there's still more to go. I'll talk a little bit about what we think is left in a moment. But just some examples of what that means, those 90,000. 80% of treatments that have been provided for Hep C have been provided to the most deprived half of the population. So these are people who are already experiencing significant health inequalities or are part of what we would consider to be inclusion health groups. So we're reaching into communities that often feel excluded from healthcare interventions, from standard healthcare interventions, which is a really important thing for us to be able to do and for us to be able to share with other parts of the NHS, which we're trying to do. Another example, in the last year, over 100 children have received DAAs, and 90% of those treatments are from the 40% most deprived areas. So, like I say, our reach is quite different to a lot of other standard kind of health services. What that's actually resulted in, well, it's a greater than 37% reduction in deaths that can specifically be attributed to hepatitis C. And I think this is data up to 2020 or 2021. So when we get Hep C in England published in January, we'll probably see that that's changed and should have gone up. But a 37% reduction in deaths attributable to hepatitis C. And what that means for the WHO mortality target, which for Hep C is less than or equal to 2 deaths per 100,000 population, we've actually already met and exceeded that target, the 2030 target for elimination in relation to mortality. So we're already achieving around 0.5 deaths per 100,000 at the moment, which is great, but there's still more to do because these are avoidable deaths. So the earlier we find and diagnose people, the less of those deaths there will be. And also more than 52% reduction in the number of liver transplants that are attributable to hepatitis C, which is has a huge impact for the individual, the community, because it means that more livers are available for transplant, but also to the NHS, because transplantation services and the management of that over time is a significant cost to the NHS. So apologies for those of you who've seen that before, but I think it's worth kind of recapping where we've got to and what we've actually been able to achieve. Next slide. Thanks. So really, this makes it look very tidy, like there have been specific phases. These all bleed into each other very easily. But really, where we started was with the people that we knew that were sick. There were a lot of people who hadn't been offered interferon-based treatments or couldn't tolerate them. There were a lot of people that we knew were ill. So in those early phases of getting people through treatment and onto DAAs, we still had relatively high rates of liver cancer and end-stage liver disease and cirrhosis, because a lot of people were sick before we even started treating them. This kind of second phase, if you like, is what we've been doing really probably for the last 5 years or so, targeting those individuals and those communities that we know are most likely to be Hep C positive and potentially at greatest risk of onward transmission. So drug treatment service populations, people experiencing homelessness, people in prison, populations where we thought that we would find most of that kind of pool of infection, if you like, and the more opportunities for transmission. There are still some of those to find, so I don't want it to look people to think that I'm just kind of saying, oh, we've done that now, we're moving on. But really the next phase, and where I think we're getting into now, but we need to get further into, is those that we don't know about, the people who we need to look for, and they don't realize that they need to be found. They don't know that we're looking. So thinking about the estimated prevalence, we're probably somewhere between 60 and 70,000 people left to find in England. And estimates of historic risk are that they would account for probably about 40,000 of those. So up to 2/3 potentially of people who had risks in the 60s, 70s, 80s, 90s, and are now completely unaware that they've been at risk, unaware that they've had a virus, unaware that they need testing, unaware that they might need treatment, and because of that are quite difficult for us to find. There are ways for us to do that, but it's not necessarily as straightforward as some of the communities we've been looking at so far. Next slide, please. So really, I've tried to sort of contextualize where I think we are in terms of what the focus needs to be going forward. So I think there are some things that we've done quite well. So I think testing in prisons, for example, and in a large proportion of drug treatment services, but not all of them, has been good, and the way that that's ramped up has been really effective. But that needs to be consolidated. So there are prisons that haven't necessarily achieved the level of reception testing or population testing that we would want. There are some drug treatment services that haven't done that. So we need to consolidate some of that. And we've started some inroads with inclusion health populations, like people experiencing homelessness or migrant populations, but actually we need to do some more to be comfortable that we're doing enough really to meet the needs of those populations in terms of both testing and diagnosis and treatment, and ensuring that their treatment's been effective. There's obviously still an issue around addressing current risk. So people who inject drugs, especially those who are outside of drug treatment services, outside of structured treatment, people maybe using harm minimization services, needle exchange services, and migrant populations who are ever changing. There is current risk there that I think we need to potentially pay more attention to, and make sure that we're addressing those needs. Historic risk, which I've just mentioned, I think that there are a number of opportunities now for us to start looking at some of that historic risk. So the emergency department opt-out testing, which, as people will have heard, is extending to the next 47 type 1 emergency departments. Primary care, where we're becoming ever more enmeshed in practice-based and PCN-based and integrated care board-based relationships with primary care to make sure that we're finding people whose risk might be historic, and obviously antenatal testing and directing people towards the web portal, which seems to be an appropriate way to target some of those people who think they might have been at risk a long time ago. And then there's something, I guess, around legacy that I just wanted to briefly mention. I think there will be something. I think over the next 2 years, this needs planning very carefully, so that when there isn't a Hep C elimination program anymore, we know who is responsible for ensuring that elimination is maintained. There will be an element of that that will be delegated to integrated care boards as part of the existing work that's already being delegated around liver and hepatology. So I think there's a significant piece of work there to do with integrated care boards as the local kind of management of health and care. There's making sure that drug treatment services continue to be commissioned to provide testing to their populations, even after elimination, because there will still be instances where Hep C infection crops up. There needs to be adequate surveillance, enough testing happening really for us to be confident that communities will be able to pick up those cases of infection when they happen. And health and justice need to obviously retake on the responsibility for overseeing reception testing, which since the Hep C elimination program's been running, has gone from reception testing has gone from less than 10% to over 75%. So that's great, but when we're not here anymore, we're really going to need health and justice partners to make sure that that continues. And I think the other thing in terms of legacy that we all need to think about is those harm reduction services that aren't necessarily readily available in communities at the moment that are going to be very much needed to prevent ongoing infection, both initial and reinfection. Next slide, please. Oh, sorry, let me stay on that one. Just the other two things to say about that one. Underlining all of those things, there's a significant piece of work, I think, for us now around driving value and efficiency. We're not in the easiest of funding environments as public services, and we've had fairly generous settlements of over recent years, and I'm working very hard to make sure that continues. But I'm being asked to provide ever more information about value, efficiency, cost benefit, and so on. So there's a significant piece of work there. And a significant piece around data, evidencing elimination, which I know that Ruth will pick up on, but also evidencing need, because as we move forwards and we think we're getting towards the end, there are still going to be pockets of need that we haven't identified and we haven't met, and we need to get in there and make sure that we do, and it's really important that we identify those. Okay, next slide. So I suppose what I'm saying is, what got us to where we are now won't get us to where we want to be. There are some limitations that we're facing at the moment. So the economic environment, obviously, you're all aware of, both generally and within public sector finances. It's not easy. We are seeing at the moment ever bigger programs with bigger costs and bigger pressures. So, for example, the 47 additional type 1 emergency departments is going to significantly impact the available Hep C elimination budget, because we need to pay for the testing in all of those, which is in the several £1 million mark. So, you know, it's going to mean that we might have to make some difficult choices about doing one thing instead of doing another, rather than doing everything. There are fewer easy wins. I think every time you're out there and you're testing and you find somebody who's positive, that's a win, but it happens a lot less than it used to, and we understand that, and that can be quite dispiriting. I think data quality and availability, which I'm sure Ruth will touch on, is a potential limiting factor for us to be able to evidence elimination. Prevention services, which are kind of a perennial problem that we need to find a way of addressing. Designing an effective legacy, which I've mentioned, and hidden infection, or in other words, places that we haven't looked yet. Next. But on the good side, all of you have achieved amazing things. All of those things that I showed on the first slide are quite incredible, and I would challenge any other program to be able to show us the measurable differences that they've made that compare to what the ODNs, the Hep C Trust, the drug treatment service providers, His Majesty's Prison and Probation Service have all made in relation to Hep C. The strides forward have been quite incredible, and you've achieved that. The other thing I think to say is we've never been closer to elimination than we are now, and that will just keep getting closer and closer as we roll out things like the emergency department testing and antenatal, and we find more and more people. We're going to get ever closer, so keep that in mind. There's a goal that we're all heading towards, and we've got a full 2 years to plan, deliver, and evidence that achievement. There are some great opportunities now, as I've mentioned, and no one knows how to do this better than we're collectively doing it. Everywhere I go, I was presenting in Madrid about 3 weeks ago, and several people, when they stood up to do their presentations, were saying, I'm looking forward to hearing what's happening in the UK or what's happening in England, because they're always ahead of us, which was really great to hear, and great that we're able to share that. But it's recognised amongst other countries as well that we're making really great progress. And last one, I know you can do it. I know all of you can do it. And whether it means anything to you or not, I believe in all of you, because I've seen the things that you've achieved in the face of adversity. So I am really grateful, and I know we ask a lot of the ODNs and the drug treatment services and the prisons and all of the others, and we pile on request after request. It's because we're ambitious, and I think you are too. And next slide. If there's anything at all that we can do as a national programme team to help you do what you need to do to get us to elimination, then just contact us at any time. The door's always open.
Thank you, Mark. It's good to be reminded that that we are actually ahead of the field. I think genuinely England is. So it's a nice place to be in. I guess it's how we maintain that, isn't it, really?
Yeah.
Thank you for that. To hear. We're going to pick up questions at the end. So if I can move on to Ruth Simmons. Ruth is going to also share the data with us that underpin a lot of the trajectory towards elimination and then maintenance. So, Ruth.
Thank you. Hello all. I'm sure a lot of you know me, as Mark said, probably heard a lot of this already as well. But I've tried to pick out some of the gaps and present some of the data and also some of the new stuff we are as a group pushing forward. So next slide, please. So Mark's really kind of already gone over this, kind of where we're up to, where we're working towards, and also mentioned that the new Hep C report will be out in January with all the new data. So we're working towards a reduction in incidence, a reduction in mortality. We're also working towards a proportion of evidencing the proportion of people who are diagnosed, who are living with chronic hepatitis, those eligible for treatment, accessing treatment, and then also the prevention side, which is our safe injections, blood safety, and the access to needles, syringes amongst PWID each year. Next slide, please. So the first one being the mortality target, as Mark says, we've crushed that already, and that's the top graph showing where we are against the WHO elimination target. The graph below is what we've been doing to investigate how we evidence this, to show that we have looked at every possible way to evidence the mortality target. So looking at what we already present, which is the blue line, which is what is written on death certificates, but then also doing some linkage to say, are we missing any flags for hepatitis C, and seeing how far, what an increase that would be if we got the top level data of, we've looked at hospital episodes, we've looked at diagnostic data, etc. And we're actually still below that target, which is great news. So the data gap, as Mark said, some of these will be preventable deaths. You know, should we be investigating what the causes of deaths are? And actually, should we be thinking about a national target to reduce Hep C related end-stage liver disease and HCC further, not just working towards that WHO target? The other data gap that WHO would like to have evidenced is using an attributable fraction. So taking the fraction of cirrhosis and hepatitis HCC, let's not attributable. Thank you, Stephen, for laughing at me. Attributable to viral hepatitis, and then we take that sort of attributable risk and we put it against the number of deaths associated with cirrhosis and HCC. I don't know why I tried that again. And so if you go to the next slide, please. So that's how we do it. So what we're looking to do, and we're not sure how we're going to do this yet, so whether we We pick out a number of centres, or we do a random sample. It's about getting individuals on board. So this is kind of a shout out if you would like to be part of this. So we really want a representative samples of patients with cirrhosis and HCC. And then we want that baseline. Then we want to add in the proportion that is due to or have the attributable sort of viral hepatitis status of these patients. And then we would calculate that attributable fraction. And then from that, we would then take that fraction and put it over the number of deaths. And that should give us another evidence, another sort of data evidence to give to WHO. And this is actually one of the things they are asking for. So we need to do this. So anyone who's up for being involved, please do let us know. Okay, next slide, please. So we've got our annual incidence target that we're working towards, and we can definitely see that we have reductions in HCV prevalence, which is really promising. But what we do know is this is probably driven by treatment, a lot of treatment, and we still have that risk of onward transmission of new and reinfections. What the data gaps being is really understanding those incident infections. So we're thinking about whether we roll out avidity testing again. So maybe having a look at the UAN samples to identify those recent infections. Rollout of sequencing, what role can that play? So look at onward transmission, clusters, where are we seeing clusters, and what is missing that's happening in those clusters that we should be doing on a public health agenda. We've got the second round of needs assessments, so let's see what comes out of there and what incident estimates will come out of that compared to UAM, and also our sort of sequential testing data. And then we can triangulate that and really refine our data model to look at those incidence models. Again, we've got our risk of reinfection. How are we measuring that? And also we've just got ethics sign up for some qualitative work to go out and sort of interview those who have been reinfected. What was missing? What should we be doing? How should we be supporting them? And then also, as some of you will be involved in, is we're starting to roll out NSP monitoring, because we need to ensure that we have that prevention as well as treatment. Next slide, please. So our 90% of people with HCV diagnosed, now this is going to be extremely complicated, and I'm hoping everyone will be on board to make this, because we're going to have to work together to do this. So we've sort of, if we take our 2015 snapshot of our modelled chronic prevalence, and in that we'll have our ODN data, we'll have our observed RNA positives, which in the surveillance data will have those that have been treated, those in SGSS, and can we pull those together and say how many have we diagnosed of that 130,000 individuals? But it's not an easy ask, because it's a very dynamic model. So we've got our deaths that are leaving, we've got our emigration populations, which we're not really sure about at the moment. We've got our immigration in of our positive individuals, and we've also got our incident infections. So it's not an easy ask to sort of say, of our 130,000 people, how many have we diagnosed, because there's a lot of movement between that. We have started looking at that with the data already, and we've kind of estimated between 52 and 80,000, 52 and 80%. I mean, that's quite a wide estimate at the moment, but it would be really good to start to feed in some of the data the ODNs have. So thinking about previous treatments in the interferon era, getting the missing data on treatment into the treatment database, or getting the blue tech data to sort of really flag those who have been treated and are now and have been diagnosed and have been treated. And then we've really got to think about how we identify those undiagnosed fraction, which Mark was mentioning. How do we find those? How do we sort of evaluate case finding interventions to say which ones are effective? And if, as Mark says, you know, we don't have all the money in the world, which ones were the most effective and which ones should we continue doing? Because we know that will give us our sort of cost benefit, which is the big thing that ICBs are asking for. They don't want cost effectiveness, they want cost benefit. So what data can we use to show them that we are beneficial to them of saving them money? Next slide, please. So the other thing Mark mentioned is the ED, and I just wanted to bring up some of the data that we have published recently on the first round, and these are sort of the distribution of those newly diagnosed. So we still do have people out there who haven't been diagnosed yet, and a lot of them from the ED work were older individuals, actually, sort of 50-year-olds and over. We've got a lot of sort of white other individuals in there, but actually a fair amount in other populations as well, and those in those most deprived. Now, just a kind of like plea, as Mark said, it's all about the data as well as kind of doing these interventions, because we can then show, we can evidence what we're doing. And from these data, we hope that that will then feed into some of the discussions about what population should we be focusing on now? Where are those new diagnoses compared to those that you've already diagnosed? And are they different? And should we be focusing our efforts somewhere else? Next slide, please. Okay, what's this one? So this is the treatment target. So this is the last year's data. So we'll be presenting the new data in the new year. But we know and as Mark said, we're treating loads of people. We know we're getting to those individuals, but it's about the evidence as well. So we can see there's a bit of a disparity between the BlueTech data and the database data. So we're kind of underestimating, I'm sure, that sort of cascade of care of getting to that SVR. And how do we fill that gap? So we're already talking about how we get the underreporting higher. Mark and I have been trying to get BlueTech data so we can get that raw data and start linking it up. Thinking about those missing SVRs, so we'll probably be able to feed a lot of that in with the ED data as well. So where they're testing in emergency departments, we'll be able to feed back to ODNs to say we actually now have a negative RNA, and more recently, we have sent out a lot of RNA data to all the ODNs who have DSAs with us, data sharing agreements with us, to share back all the RNAs that we have in our sentinel surveillance and what's happened to them. Have they died? Are they now negative? Are they in the treatment database? Or are they still positive and we're not sure what to code them as? So hopefully at some point we'll have a real good understanding of our population. And again, sort of understanding our reinfections, so doing those qualitative interviews and refining that cascade of care. So hopefully in the next then the report that will come out, we've been trying to flag those spontaneous clearances, those RNAs that are negative but we don't have an SVR, to get our best estimate of coverage. Next slide, please. So these are sort of filling the gaps. So as I said, we're looking at the BlueTech feed. We want to refine that patient pathway. Want to sort of start to share the data to refine that chronic population. So do we take a cohort, which I've got down, a developer cohort, who still needs treatment, and can we feed information back and start sort of classifying people, saying these people have been treated, there are completed individuals, these still need action, etc. So when we go into that evidence, we've got all that data there to do. We're trying to increase sentinel surveillance coverage and data quality so we can evidence the ED work, so start discussing a data tool for accessing surveillance data, so you guys can use the surveillance data, so you don't need me to send that data out. And then also sort of investigating the differences between those who we've found and treated and those who we have not, and where should we be focusing. Next slide, please. I think I'm running out of time. How am I doing? 11 minutes. Okay. So just to touch on a few things that we've started doing, which you guys may not have been involved in or heard about yet, but just to go through. So one of the key things that is within the WHO elimination strategy, sort of evidencing, is stigma and human rights. So we're starting to have that conversation. So next slide, please. So earlier this year, we ran a workshop, stigma workshop, which was attended by NGOs, NHS England, UKHSA, academics, and those with lived experience. And we started to talk about kind of what should we be doing? There is a gap. We all know there's a gap, and sort of just starting to have that conversation. So we have people who had lived experience who talked about how stigma has affected them. Next slide, please. We had Carla Trelaw, who was from the University of New South Wales, who have done a huge amount of stigma work already. And next slide, please. And she talked about what they've done and some of the questionnaires they've done and how it really impacts individuals' access to care, about what they sort of follow-up appointments, that, you know, that stigma really does impact that care cascade. Next slide, please. And then the World Hep Alliance really did highlight this as well, sort of barriers of diagnosis being that stigma and discrimination is in there. Next slide, please. And then also that they, alongside ECDC, are piloting a worldwide stigma questionnaire, which they will be piloting in the UK. And the Hep C Trust and British Liver Trust are in those conversations with us as well. So that's going to be going live. We're looking into ethics and what we need, but that will be going live very soon, and being translated into a number of languages. So that is on the sort of horizon at the moment, and we're really trying to start that ball rolling. Next slide. But going through all the literature and everything we talked about, these were the key things, sort of top being the big sort of size being the sort of the biggest sort of impact, is that stigma and discrimination is a barrier to treatment, barrier to testing. Knowledge reduces stigma, reduction of quality of life. There's the barrier of vaccination as well. I know we're talking about Hep C, but also bringing Hep B into that as well. And then there's less healthcare engagement when there's that impact of stigma. Next slide, please. So so dashboard version 2. So we've done a bit of, next slide, please. We've done a bit of rejigging of it, spoke to a lot of stakeholders, you guys, and you've really inputted into it. And we've really tried to answer all your requests and come up with a new dashboard for you guys to use. So that's going to be going live in January, I think, or the beginning of next year. But the team has been doing a lot of interaction with you guys to get that going. Next slide, please. And taking on a lot of the feedback that's come back from focus groups, from the different groups, the ODN stakeholders, or anyone who uses it. And then we've been trying to work to produce something that you would enjoy using. And then my last sort of bit, just because we're in our last 2 years, so next slide, please, is just to highlight that we should also be thinking about maintenance as well. So, you know, we're starting, and Mark was sort of saying, you know, things are going to start winding down, but we don't want to lose that momentum that you guys have done. And it's been an amazing piece of work. Next slide, please. So we're looking at kind of how do we detect early warning systems, what's going to impact our maintenance. And this is our outbreaks and our exceedance that we're going to see increases, declines in prevention. We know that, you know, if you take away NSP, we may see an increase in infections. Decreased awareness at the moment, we all talk about it, but I know there's still discussions still that GPs aren't aware about sort of what the next step is. From that's discussions that have come up more recently, and we've already talked about how stigma impacts our ability to ensure individuals are engaged. So my last slide is just sort of that pillars of maintaining elimination. What do we need? So we need that structural, financial, policy, political and commission sign up. And actually going back to the New South Wales things, asking them about their stigma, what made it work so well? And it was having that sign up from all the stakeholders, but also the government as well. So I do think we need that strong, big voice and start to shout loud. We've need to ensure that it's a person-centered approach, and including those people with lived experience, the importance of surveillance and all the hard work you guys have done, and then kind of the sort of prevention, testing, treatment, you know, holistic approach. Should we be bringing all of it together, BBVs and also the vulnerable populations as well? So that was kind of my just shout at the end about how we maintain once we've eliminated. So thank you very much.
Thank you, Rita. A lot of things to think about, both from the data, but also that final slide and the stigma and all the things around it, and which clearly has a huge set of implications for us for the next 2 years and beyond, doesn't it? So I'm sure we'll come back to that in the Q&A. So thank you for that. So we're going to move on to the ODN experience now. So perhaps Sally can come in and tell us about Birmingham.
Thank you. Next slide, please. So the Birmingham ODN, or West Midlands ODN, is quite a large ODN actually. We're in Middle England here, as you can see in the dark blue on the right-hand side of the slide. And on the left-hand side, this is the catchment area that we're covering, and it goes out and extends as far as Wales. Our population is about 6 million people, and it's over 10% of the England's population. And so we've got some big cities on our patch, but we've also got some quite rural areas. And I think at the beginning of the ODNs in 2015, 2016, the size of our patch probably wasn't so much of a problem, because a lot of the treatments we were doing were hospital-based treatments with patients who were well known to services. But I think what has happened over the last few years, we're trying to find the patients who don't come to hospitals. They live on the streets, a lot of them, they're homeless, they might be in hostels. And so the geography of our ODN has actually become more of a problem over the last few years. And that's really for the Hep C Trust peers. They have to travel quite long distances to actually get to different hostels and drug and alcohol services. So it's something that we're aware of. It's something that I've been working very closely with Mark and NHS England to actually increase our peers across our network. Next slide, please. So these are some of our current projects and initiatives in the ODN, and I will talk about these individually over the presentation. But our mobile van, we might use slightly differently to other ODNs, and there's already been an increase on its use in this year. So far, we've had 16 extra days use this year. So the van is very well used for our patch. I'll talk in more detail about our use of CEPID machines, the increase in the Hep C Trust peers, but also our work with the pharma companies, Hep C Later. We've actually provided specialist intervention workers in some of our drug and alcohol services, our larger drug and alcohol services, to help us test and find more patients. Next slide, please. So this is the amount of patients per spoke site that we start treatment on, and our numbers don't appear to be getting any smaller. In fact, this year's numbers seem to be higher than the previous year, and I think that goes along with all of the good work that's happening across the patch. The University Hospital Birmingham is the largest treating centre in the West Midlands, which is where I'm actually based. And as you can see, we've actually filled in blue text for 339 patients so far since April this year. But what we are noting is the amount of resupply of medication, and that is appearing to become a bit more of a problem, and I will touch on that in a little bit more detail over the coming slides. Worcester Hospital has got quite a high amount of patients starting treatment, and that goes hand in hand with some really good work going on in one of their prisons. But we have a lot of hospital trusts that we oversee, and I'll talk in more detail about the resupply issue from our point of view. Next slide, please. One of the things that we tried to change very early on was the patient referral and the patient pathway. And so now, once we've got a diagnosis of a PCR, the referral is sent through to us on email. We register the patient at the hospital, and then we allocate them an appointment within 7 days. We would always try and see a patient face-to-face. If we can't do a face-to-face appointment, then we will go to a telephone appointment. For most of our clients now, we do not get any blood results, and very often we don't even get a FibroScan. We will always try to do a face-to-face and get a FibroScan, but we don't always achieve that. That is something that we would plan plan to do at a later stage, it does not stop us starting anyone on Hep C treatment. Next slide, please. And as I said, we may use our bus a bit slightly differently to other ODNs. As you can see on the left-hand side, our bus is quite a big big bit of kit, really. It isn't a bus that we can just roll up outside a pharmacy, get out and, drag people on and get them tested. So my own team in Birmingham use it as a clinic room, and that's how it's set up on the right-hand side. And so we have to make sure and do that the driver does a recce of the site where we're going to put it to make sure that the bus can get under barriers and there's enough room to actually get the steps out and the ramp up to the door. But the Hep C Trust peers are starting to use the bus now more for testing events, and we've also expanded the areas in Birmingham where we actually take the bus to. Therefore, we can try and get as close to the clients as we possibly can. Next bus, please. Next slide, please. And so the Hep C Trust peers are crucial to our work now, and without them, I don't think we would have been able to treat as many patients. And so we put a business case to Mark and NHS England earlier on this year, because the size of the patch with the 6 million of our population meant that we were well under-resourced for Hep C Trust peers. So we had 5 new peers starting from the 13th of November onwards, and we've got a lot of work still to do in our ODN. So on the left-hand side, you can see the community peers, and on the right-hand side, we've got 2 designated prison peers as well, Gary Henry and Leroy Kenrick. Next slide, please. And so what we're finding is we're dishing out tablets to patients, but some of our patients aren't taking the medication, and that's something that we really want to work on over the coming months. And Huggy, who's our regional peer lead, is very, very keen to work with patients to support them throughout the treatment in the community. And I'm hoping with the increased numbers that we can start to really get on top of this. Hep C Trust players are in a better position to encourage patients to take the medication. And Hug is very keen to take shopping in for clients and even buy dog food for them, get electricity smart card meters for them. Anything that we can do to try and encourage them to take their tablets. We're noticing that we're getting a lot more patients in on the wards, and we are doing some limited A&E testing here at QE in Birmingham. And so we are identifying more patients in our wards at the minute, and therefore we've just set up a system with the peers where they're going to allocate a peer to cover the QE hospital, and when we are notified of patients who are in the wards, one of the peers will come in and actually speak to the clients. They'll bring in papers, they might bring a bit of chocolate in, they might take them down to the restaurant for a coffee. And they're in a situation where they've got the lived experience. They can listen and take an interest in these clients more so than myself or maybe my colleagues can. And Huggy's remit is be kind, and they remember that. And I think this is crucial moving forward for this cohort of patients that we now need to cure. Next slide, please. And so what can we do to get the patients to take their medication? Professor Mutimer came across this study recently and forwarded it to me and the team. And it's actually a really interesting paper to look at. And so it was very clear that it wasn't just our issue in our ODN that patients aren't taking their medication. This paper is written from the States. And when we did actually look at our own Birmingham resupply for April to September, there was about 49 patients that we'd done a resupply of medication for. And when we actually looked at that in more detail, there was 17 patients that we had, or they didn't give us a reason for not taking their medication. And then there was 14 patients who had lost their medication. And when you actually look at this study that was done in the States, it was looking at strategies of how can we help patients to not lose their medication. And one of the ways that they looked at was providing bum bags. Now, this is a really good idea for people who are homeless, people who are living on the streets, people who are in tents, because very often they do say to us, I don't want treatment at the minute because I haven't got anywhere to put my tablets. So we've just had 50 of these bum bags purchased by the UHB charities. And in the next few weeks, we're going to start giving out these bum bags to our clientele who are in hospitals ready to be discharged, who live homeless, and to work with the Hep C Trust. And we're going to see whether this will help with patients in actually keeping hold of their medication, and therefore hope in the fact that they may actually start to take the tablets. Next slide, please. So as far as the CEFID data goes, we have 6 CEFIDs across our ODN. 2 of the CEFID machines are actually funded by MSD, and these 2 CEFID machines are actually sitting with the Hep C Trust peers, and it is the peers that carry these machines from place to place. And without the peers doing this, we wouldn't have so many patients tested out in the community setting. And as you can see from the CEFID numbers here, which are really quite good, we've had 101 RNA positives, and this is literally just with the Hep C Trust peers. And out of those, 92 have managed to start treatment. So this has worked for our ODN for a number of years now. And we're just working with NHS England to see if we can try and keep hold of these CEFID machines, because they are crucial really to the work that goes on in the West Midlands. Next slide, please. We've also had a needle exchange project running for 2 years. We're into the 2nd year now. These results below are from April this year to the end of September. And we did get off to a bit of a rocky start last year because the needs assessment project did get in the way of this, and then we employed a couple of peers who then went on to leave quite quickly. But we were back up and running again this year, and these are the numbers that we found through the needle exchange, and these are the positive numbers on the right hand side in red. And these needle exchange pharmacies are approached either by our ODN pharmacist and we do a formal contract, or what has worked better is when there's an informal process and the Hep C Trust peers will identify a needle exchange pharmacy and then go and approach that pharmacy. And that has worked extremely well. We've got needle exchange pharmacies in Telford, Stafford, Cannock, in Birmingham, and also in Coventry. So this work is ongoing. Next slide, please. And then, of course, we were involved with the needs assessment project, and year 1 saw our area provide 569 samples. Some of those unfortunately couldn't be processed because there were insufficient blood. But our results, I think we came quite high up on the list of RNA reactives. We had 53 reactives across our ODN over 6 drug and alcohol services and the Hep C Trust who went into the needle exchange services. Next slide, please. And this is where we're at the minute for year 2 of the needs assessment project. Obviously, this project this time is over 6 months. We are struggling a bit with the project on this this year. We've had 103 tests received up until the 4th of December, and so far we found 7 RNA positive clients. Unfortunately, clients have moved out of area, as these clients do, and you know, it's been very hard so far to actually track down some of the clients who are actually still in service. So there's a lot of work here to do to actually get up to the 500 clients that you know, that we received samples for in the last year, but it's ongoing, and everyone is working extremely hard in those services to try and achieve this part of the project. Next slide, please. And so drug and alcohol services, we have a lot of drug and alcohol services in our catchment area. And I think one of the key issues from my point of view as the ODM manager is the difficulty, because they're not all under the same provider. And that makes things quite difficult. There's also retendering that goes on at different points with different services. And what works well in one area can't necessarily happen in a different area because they're run by a different provider. I have a lady by the name of Faith Cullen who works closely with our ODN, and also Gilead linking very closely with the drug and alcohol services and feedback to me to let me know at what stage they're at with the elimination. And so far we've had 2 services that we've actually achieved elimination, and that's the one at Solihull, which is the SIAS, and also in Telford Stars. But we're working very hard with the other services, and in turn they're working very hard in trying to track down clients and get them tested. Next slide, please. So I think our ODN has probably got one of the largest cohorts of prison on the patch, and most of our prisons are run by Practice Plus, apart from Birmingham Prison and Stoke Heath Prison in Shropshire. We've done quite a lot of hits, and this year we did a hit in Onley, and we've also done a hit in Birmingham, and we're aiming for another hit at Stoke Heath before the end of the financial year. And then we've got about 4 prisons that we've actually got micro eliminations. So that's Drakehall, which is our female estate, our only female estate in our network, Swinfen Hall, Brinsford and Rye Hill. Our ODN was asked to take on the Rugby prisons because it was the Coventry CNS that actually went into those prisons. So we took those 2 prisons on as extras. We've come a long way with our prisons on our network. It's remarkable, really, to sit here a few years on, but most of our prisons now are hitting over 85, 90% reception testing. Our 2 prisons that were just running behind were Birmingham and Stoke Heath, but I have we've worked very hard with both of those prisons, and I've got an update on the next slide, please. So what have we done differently in prisons? Prisons are very, very understaffed at the minute, and that becomes very difficult when we speak to them about reception testing. Now, what we did about 4 years ago was I sort of came up with the idea that if I employed our own prison nurses, then that might make things a little bit easier. So we only managed to employ 1 out of 3 prison nurses, and we have that nurse, Hayley Allen, who is based actually in HMP Birmingham, and her remit is to work on behalf of the ODN. I was struggling to recruit prison nurses because I was just really struggling, because the prison were also trying to recruit similar people to me. But so we employed our own ODM prison nurse in Birmingham. And then what we've done in Birmingham this year, to increase reception testing, we bought in OraSure testing. and this has worked remarkably well in this prison. And this is done by the champions. The prison champions loiter and hang out in the reception, and as patients or prisoners are coming through, once the initial assessments have been done, the prison peers and champions speak to them about Hep C testing, and they give them all out an OraSure test, and they show the prisoner how to do the test, and the prisoner then does the oral swab himself. Any antibody positive cases are then put onto a Cepheid machine, because Hayley, our prison nurse, has a Cepheid machine in Birmingham prison. So within about 48 hours, any positives that are identified on the front door are then taken through, and Hayley sees them and puts them onto the Cepheid machine. We also did a hit in June this year, and we only found 6 new cases, which was good to find, because there's been a lot of work going on, and we have found the RNA positives, as you can see highlighted in red there, 20 positives for Q1 and 13 positives for Q2. If we look on the right hand side of this slide, we have also got Cepheid machine in HMP Hull. Now, Birmingham and Hull are both remand prisons, and they've got similar numbers of men, and these men, they come in and out very, very frequently. So it's very, very hard to keep on top of what's happening in the prison. But in Hull prison, they do matrix antibody testing at reception, and once again, anybody positive antibody will go onto the Cepheid machine within 24 hours. And in Hull prison, they are getting between 8 to 10 positives a month. They also had a hit in September 2021. Now, there is a discrepancy in the amount of positives to the amount who actually start treatment, and that's because of the churn of prisoners moving out or going on to other prisons. And we use the Follow Me Hep C Trust project to try and follow through with those prisoners when they actually leave prison. Now, just in red at the bottom of this slide, I've just identified Stoke Heath prison. I was in this prison yesterday, and we've been working very, very hard with the prison, who in turn are working extremely hard to try and increase the reception testing. There is a lack of nurses in Stoke Heath prison, and so if you go and speak to them about increasing reception testing, they just don't have the staff to help out with that. So what is happening in that prison right now, and I'm hoping to update people over the coming months, is the resident peers are doing the testing using dry blood spot tests. So we have, well, the Hep C Trust peers and the prison have actually trained what they call their hawks, which is the health and wellbeing champions within the prison, to actually do the testing of the prisoners. And we have turned the reception testing around in the last few months. That's gone from 13% up to 51% when I was in that prison yesterday. So we've got a lot of good work going on in the prisons, and hopefully I can update people sometime in the future about how Stoke Heath is doing with their resident peers testing. Next slide, please. And so we're all involved in the web testing portal. This is another way of anyone in the population testing for Hep C. And so far for our ODM, we've had 4 positive cases referred to us. All have been discussed at MDT. One of the patients had already known about his Hep C and already been referred to Sandwell Hospital. And then we've had 2 recent ones for Stoke and 1 from Walsall. Hopefully we might see some more positive cases from this source, but so far it hasn't yielded too many extra clients for us. Next slide, please. So these are our remaining challenges for our ODN. It's a massive task that we've still got here in the Birmingham ODN. We have just appointed 4 GP champions, and we're hoping to get them up and running hopefully by about mid-January. I'm just waiting for their checks to be done. 2 of the GP champions already worked with us running the MSDI tool with a project we did a couple of years ago. So that's really helpful that they already know and understand what we need. We're just trying to get an advertising campaign for the web testing portal going by getting adverts out in Metro and local newspapers. We've got A&E testing discussions going on with both Birmingham and Coventry, which we hope to get off the ground next year. We want to be involved in antenatal testing project. And then for our ODN, I've got a lot of work in going back through lists of lost patients, updating lists, looking back at historic cases, and generally going back with some of the information that Ruth and her team are providing to us. I think that's my last slide. Thank you.
So thank you for that. Thank you for the summary of where things are in Birmingham and surrounds. And I'd like to now ask Stuart to come and tell us about what's happening in the northeastern Cumbria. Stuart.
Yeah, thanks very much, Steve, and thank you for the invitation to talk to you today. So I'll get started. So northeastern Cumbria. So we're right up the top of the country, as I'm sure you know, 3.7 million population that we cover. Quite a challenging ODN, largely for geography. We're more than 100 miles across and more than 100 miles north to south, with quite a lot of areas of deprivation. There are 7 hospital trusts involved in treating hepatitis C, but historically they have been under-resourced, despite the fact that we're getting all this money from NHS England. So the services are quite lean. We have 17 drug service providers in 7 prisons. So very similar to Sally, we have all the same problems with those providers. When we began the elimination several years ago now, this was the data that Public Health England, as it was, gave us for the northeast. We didn't have data for North Cumbria, and it was suggested at that time there were 6,500 RNA positive individuals. So the first piece of work that we did was we got all the positive cases that were known directly from Public Health England. This was prior to everyone getting this data, and we mapped it. And we had all the treated cases that we knew about from our databases, and then all the untreated cases. And this really helped us get a picture of where the hepatitis C was in the region. And we also found that, probably not surprisingly, the closer people were to services, the more likely they were to have treatment. Fairly obvious, but we demonstrated that. And really, this has been an ongoing process with the lists of patients constantly trying to chase the patients, updating that. But reinfections, as you'll hear about later on in our region, is a problem. So trying to have an accurate picture of exactly what's happening at any one time on the number of cases left is quite tricky. Similar to what's happened in Birmingham, we very much simplified things as much as possible. Given the large geography that we have, we start a lot of people just over the telephone. And this is a simple pathway as I think you can probably get. So if people are RNA positive within the last 6 months, they have a telephone consultation. If they're uncomplicated, we can get hold of them and it all sounds fair play. The drugs are then delivered to those patients and they get telephone follow-up as needed, and then blood tests after. If there's any suggestions of any complexity, they're discussed in the MDT and seen in whatever clinic that seems most appropriate. And with the simplification, the numbers are increasing. So similar to Sally, we're treating, this year we'll have treated the most. I think we're going to exceed 1,000 patients this year by April for the first time. So no sign of drop-offs. And the 2 main sites treating are Newcastle and then South Tees. Now, when the sequin came in this year, we did a quick audit last year to find out the number of people who started within 28 days of diagnosis rather than referral, and it was only 2% of people. So that was a major concern for us. So with all of this, we've really streamlined the service as much as possible, and we're managing more than 95% starting within 28 days of referral. So I think the sequence for us has been really helpful to streamline and improve efficiency, I have to say. But there's no shortage of patients for us still at the moment, as you'll hear. Prisons has been a major focus of our work over the last decade, really. So I'll just share you with the journey here, because it's quite interesting how it all began. So we started setting all this up in 2013-14 when we looked at Hep C in the prisons then, even before elimination was even considered at that point. And at that time, only 8% of people were being tested for hepatitis C, with a very high rate of positivity. And only 4 people a year were being treated, and they came to my clinic in chains. And so after that, we developed the universal offer that began in March of 2016 with dry blood spot testing. And in the beginning there, we had an increase up to 35%, which at the time was very impressive, but clearly well below today's standards. And we introduced telemedicine, so video clinics and nurse-led inreach, which was novel at the time, but obviously everyone does that now. And then this year, we have just reviewed 5 years of testing and treatment in 3 of the prisons on our patch, all the ones in the north of the patch. So we've tested over 20,000 people in these prisons, and I'll just show you some of the data because it's quite interesting. So at the top there, you have the grey line is the number of receptions, and then the black line is the number actual tested. So they're getting closer together. And at the end of this period, it was 76%, and that is slowly rising month on month. So we're slowly getting there. And then the graph below is the antibody positivity rate. So you'll see there was a drop off in testing during COVID, with higher rates of antibody during COVID, suggesting probably more targeted testing. But what about RNA rates? So the top graph is the RNA positivity over the total screened. And you can see that is falling, which is good, but it still is around 6%. So 6% of people going into these prisons are still RNA positive, suggesting a significant burden of disease. And then the graph below is the rate of RNA to antibody positivity, which is falling. So I guess this is encouraging, that showing we are making progress at reducing the frequency of cases in the community, but we've still got a long way to go. And then you do not need to look at the details of this, but this is the more than 1,000 people that we've treated. And this highlights the problem with, it's not straightforward just to say so-and-so started treatment and they achieved an SVR, because so many of the patients have a reinfection, or they don't complete the treatment, or we lose them to follow-up. So Amy, who did this work, went through all the cases really carefully to try and then work out what on earth happened to them. But let's distill this down into some easier to understand figures. So over that period, of those 1,000 or so people who were treated, only 9.7% of people weren't started on treatment. So I think that suggests that we are getting people on treatment quite well. 72% had a documented SVR, and we all know that we get lots of loss to follow up in people who go out of prison. This figure does increase with time as we catch them when they get tested somewhere. And we also had, because so many people were tested so many times here, we had a unique cohort of people who had a negative Hep C test initially and then became antibody positive. So we were able to work out the incident rate. And you can see that the incident antibody rate and RNA in this population going into prison. So there's still a lot of cases, new cases, which is a worry for us in our region, despite all of our hard efforts to eliminate. And 15% of the people had a reinfection following SVR. And you can see the rate there, which is higher than the national rate that Ruth presented of around 7 per 100 person years. And then we've done hits. We've done 5 in our region. These are just the results of those with new cases in Durham and Northumberland that were part of this work. So you can see around 1% of people positive. So I think this tells us the reception testing is working, but there are still cases who creep through despite the reception testing. And we're trying to understand the reinfections, whether they're happening in the community or whether they're happening in the prison. So we've got a piece of work going on with that at the moment. So a bit more about reinfection, because we seem to discuss the same people in the MDT over and over. So another of our fellows, Sumar, looked at this formally again in the north of the region. So we had almost 800 people who had achieved an SVR, and then of those, just over half had follow-up blood tests after SVR 12. And you can see of those people, 12% had a reinfection. Some of them clearing, but many becoming chronic. So we do have a problem still with reinfection in our region. So we work very closely with the team from the Hep C Trust, and they are doing great work going out to try and find patients with us in the community. But they've done this really nice novel project where we call it test, trace and treat using peer workers. So anyone who has a recent infection or a reinfection gets invited to essentially be contact traced by a peer worker. So they consent to that, and then Mark and the team try and make contact with these clients, and then ask them to bring potential contacts forward for testing. So overall, about half of the people accept the invitation to be contacted or bring contacts forward, but actually only around 1 in 10 actually brought contacts forward. But of those 120 contacts that were brought forward, 37% were RNA positive. So this is a very good way at finding people who are likely to have hepatitis C. And then importantly, we managed to treat 77% of them. So I think as we move towards elimination, I think this is going to be one of the key ways to really get in and get those final cases. And this is very cost effective. When we compare this to the number of cases you get from the web portal, which must cost quite a lot of money, this is quite cost effective. And it's become clear that the harm minimization advice that people are getting is extremely poor. So Mark and the team have developed this pictorial guide to risk, essentially. So they speak to the clients and go through asking them to spot the risks to try and get them to understand where they may be putting themselves at risk of transmission. So we're just about to embark on a formal evaluation of this. Some other things that we've tried in custody suites. So we've been testing in Northumbria, Cumbria and Durham Constabulary. And we've tested over 500 people in this setting. So about 6% of people who would theoretically be eligible to be tested. But we see quite a high rate of antibody positivity in this group, 12%. And then 5% of them are RNA positive. And again, a fairly good rate of commencing people on treatment as a result. And also this does provide the opportunity to catch a few of the people who we haven't documented an SVR on. We've tried quite a few things that have failed. Here's an example. I wouldn't say a complete failure, but disappointing. So we got a Gilead fellowship back in 2018-19, and we put a lot of work into a training package for pharmacies to do testing and pathways for referral, etc. And we aim to introduce this in 8 pharmacies. 8 were all were induced into the project, but only 3 of them ever actually tested anyone. But one of the practices has done 5 rounds of testing, finding RNA positive cases every time. And overall in this work, we've found 25 cases of RNA positive, and 21 of the 25 have started. So we're planning to reinvigorate this work, but actually use our team going out and trying to go round week by week to different pharmacies to test everyone and then treat them shortly thereafter. Another area that failed early on, although we are trying to reinvigorate this, was the GP screening tool that was developed by MSD. So we ran this through Cruddas Park, which is one of the most deprived GP practices in the whole country in Newcastle. Serves around 10,000 population. We put the original tool in it and identified 1,627 people at risk. And clearly that wasn't realistic to test all of those people. So one of our fellows, Jenny, went through, looked at them carefully, and ultimately invited 98 people to come forward for bloods, and only 3 turned up for testing. So clearly this was not the right way of doing this, but it was an introduction. It was a lot of hard work. And now in a number of practices across the region, there's a study going on looking at a pop-up that comes up to remind GPs to test this person at risk. So what next for us? Lots of things similar to Sally. We're continuing very active tracking using all the various databases. We're aiming to try and get micro-elimination in all of our services. Some of them get micro-elimination, then lose it. So it's a challenge. ED testing, so we're working that up for Newcastle, and James Cook in Middlesbrough have just started. GP champions, we've got 2 informal ones, and we've just got Mark's just very kindly given us approval for 5 or 6 across the region. So we're just setting that up, which is good. We still don't have a van. That's a slightly sore point, long story, but that is progressing, and we're likely to have that very soon. We'll continue with the test, trace and treat program, revitalize the pharmacy testing, as I've mentioned already. And we're going to try and promote the web testing tool. We haven't really done much on that at the moment, given all our competing other areas. So just to finish off, we have made significant progress towards elimination, but there's a heck of a lot more to do in our area. There are many barriers to overcome, but we like problem solving and finding solutions. But this is a great opportunity, as Mark has said, for us all. It's a once in a lifetime opportunity to eliminate an infection. And that's a really good motivator to get people on side to help us eliminate. And really big thanks to all the team. I mean, there are loads of people involved in this work. We couldn't fit them all on the slides. Thank you. They do all the hard work, and I'm here getting the credit. So thank you to them.
Well, thank you, Stuart, as well. I mean, it's really good to see all of the initiatives that are happening in Birmingham and with you. It's great to see. And so thanks to all the speakers. And so if people want to ask questions, please put something into the either the Q&A or the chat, and I'll relay them. What I'd like to do first of all is to just pick up perhaps on something that you raised, Stuart, which I think has a theme that links some of the talks, which was about as we move towards elimination, we're going to have a way of sort of outbreak management and contact tracing, exactly as you really described. It's always struck me as a very bizarre thing. You get salmonella, public health turn up at your door and do lots of stuff, but we've never done this in this context. So I guess looking at the role of the peers, because they're clearly the people who are so well suited to this, as we move into this phase, how do you see that working, Stuart?
Yeah, so I think that's a good question. I completely agree with you. We recently had an HIV person who slipped through the net, and all hell broke loose that person hadn't been tracked down, and the infectious diseases people were going crazy. And I'm thinking, well, look how many reinfections we have for hepatitis C that the systems don't seem too bothered about. So we absolutely have to do this. I think the advantage of the peers are that they can motivate people into coming forward for testing. I mean, we have all the issues with stigma, and we were also concerned that some of the people may be fearful of retribution if they said, well, I've got hepatitis C, do you want to come forward for testing? There may be some consequences to them. But that wasn't the case in the questionnaires that we did with the patients. So I think it's definitely something that needs explored. There is some modelling data from Ryan Buchanan and the team in Southampton suggesting that this sort of approach, the bring a friend, if you like, approach, is a very cost-effective way of bringing people forward. But I think there always will be difficulties given if there's homeless people, difficult to contact, etc. It's perhaps not as simple as contact tracing in other scenarios, but it really should be funded, I think, and thought about carefully by experts, if you like.
Thanks, Stuart. I guess linking a little bit into it was, and I don't know, Ruth, when you were talking about your data gaps, and one of the things that was quite striking is that people with severe liver disease still have a mortality. And again, it was just linking to the peers and the stigmas, whether we need to be thinking more about the holistic side of this. The proportion of the clients that smoke is still really high. and I'm not sure we've been very systematic about addressing that, as well as the alcohol side of it. And it's whether the work that you want to do in that group will help tease out some of that as well.
Yeah, no, absolutely. And it is how we it's how, I suppose, one of the big things is like the ICBs and trying to get them on board, and where this lays, you know, there's like 40 odd ICBs, and all of them will have different agendas and different wants to do with the money that they've been given. And how do we ensure that we're not missed? And how, as you said, how do we do that as a sort of well-being, sort of holistic kind of message? So it's badged with a range of things, not just Hep C on its own, but that they're, and we've seen it with the peers and everything that, and you and Sally and both Stuart were saying, you know, it's not just about the treatment, it's about kind of what's the additional support that could be there, sort of the sort of home, the shopping, the support, all of that, and how we badge that and show that that's the benefit and the benefit of the peers, etc., to support going forward, because we definitely don't want to take the foot off the pedal as we sort of remove some of that funding that was there. But how do we show that it's so important, and it is doable, and how we badge that. So yes, that holistic discussion is being brought up quite a lot.
Thanks, Ruth, very helpful. I guess, Mark, did you want to just comment about the peer programme and where you see it going overall, as the role will inevitably change as we move from things like
Yeah, well, I suppose one of my hopes as we move towards the kind of the maintenance home, if you like, of elimination and maintaining elimination. One of the things I'm working on nationally with the hepatobiliary clinical reference group is how we increase the focus more generally on liver services anyway across England, because there are generally quite bad outcomes and worsening outcomes for people with liver disease. So whether we can build liver networks as part of an NHS England transformation programme that would then make sure that this was all part of a kind of statutory responsibility with a specification for integrated care boards. And I see peers as still having a very important role within that. If you look at any other part of the health system, we've got care navigators, or whatever they happen to call them, in many different services, including in GP services. All the receptionists in my GP service are now care navigators, but actually having people who can do more than or different things than the clinical staff is becoming much more kind of prevalent, I think, across a number of services. And I see the peers as still having that kind of really key ability to impact on people's health and their ability to engage in society and to become better and to have positive outcomes. So I certainly see that as being something that I would like to continue, and maybe it widens, and maybe it does become more about wider health inequalities or health access, and wider sort of liver care as well, and wider BBV care.
Everybody hugely supportive of that agenda, and trying to sort of link it together just seems so obvious, doesn't it, really, to gain the added benefits. So I think we're very supportive. There is a question from Brendan on the chat about, who's asking, in those running pharmacy test and treat, do you have data on reinfections in that setting? It's saying there's a poster showing that reinfections were low, that if that was other people's experience. Stuart, Sally, any?
I haven't looked at that, if we're perfectly honest. The numbers are not that big, so I think that'd be something to look at going forward if we can effectively increase the testing using our teams going out, and certainly that will be a useful thing to look at. So that's a good question. Thanks.
Any experience there, Sally?
No, I haven't looked at our reinfections, but I will go back and look at the numbers that we've actually got positives on and look at that.
So I think I'm actually got a picture on reinfections. a very valid point we can look at. Thanks. The next question, Susan, how can we tackle the issue of tracing migrants with positive RNAs? Are there any specific initiatives on this? Any comments? I don't know, Mark, from a policy perspective?
Yeah, I think, I mean, we're obviously imploring people to increase the amounts of migrant testing that are taking place, and obviously we're seeing a lot of migrants coming through our emergency departments, as Susan's mentioned. I think there are a few things. So obviously there are systems whereby we can flag on hospital records on the spine, for example, if somebody has a diagnosis, so that if they attend again, then that, you know, that can be flagged up for people. But also, I think there's potentially work that Ruth and the team at UKHSA can do, helping with that kind of data linkage, so that if people turn up, if we've got positive results, for example, for somebody and we don't know where they are, UKHSA, if we've got the right data sharing agreements, might be able to find them through other data sets to be able to give us an idea about where they are. Ruth, I don't know if that's something that...
Yeah, no, I was going to say a similar thing. So definitely been trying to share with ODNs who have lost people, as in like trying to work out where they are. So there's two different ways. So the one being that the RNAs that we have, then being able to show if they've been treated somewhere else, and if they are residing somewhere else as well, or being tested somewhere else. But the other one is to work directly with ODNs who have been sending us lists of their sort of can't find these individuals and where they may be, and sort of highlighting if they've been tested somewhere else, or we can run them through the spine and look at their residence postcode and the GP that they are now registered with, to try and help sort of direct conversations, so you can reach out to the ODN that they now may be based in. What would be nice going forward, and I mentioned in my presentation, is if there could be a front end where you could sort of come in and search for the patient yourself with all that surveillance data, to sort of say, oh, that's where they are, and start that conversation, so you don't need us as the middleman. That may take a little bit longer to set up, but definitely, even from a Hep B point of view, that's going to be very helpful. And we do recognize that, but it's just trying to get all the sort of boxes in line. But yes, happy to help if ever you need that support of where the person may now be.
Thanks, Ruth. That will be really helpful. I completely agree. So it's a really good idea and a thought for the future. So I think we've run out of time, I'm afraid. Just like to thank all the speakers. It's been great to hear what's happening on the ground in two of our ODNs, and some fantastic ideas that I think we can put into practice. And thanks to Mark and Ruth for that, the view of where we're going, what needs to happen. It's also very inspiring for the future. And so thanks everybody for joining, and keep up the great work. 2025 is not that far away. Thanks to everybody, and goodbye for now.